Chapter 5 focuses on ICD-10-CM guideline chapters 12 through 21. So last week we talked about 1 through 11, and that was a lot of information there. 12 through 21 is also going to be equivalently a lot of information. However, I think you're going to find this section of the guidelines to be maybe a little bit more relatable. Starting with chapter 12, because let me back up. Two of the more important, I shouldn't say important, but sections that you will probably frequently visit from last week's lesson is going to be the guidelines for chapter 4, which would be what? Metabolic, endocrine, nutritional, and metabolic disease because of diabetes and the guidelines specific to that. And then the other one would have been the circulatory system with the hypertension, CKD, and heart failure guidelines. So you will definitely frequent them and visit those guidelines more because um, I can't say this enough. Don't try to hold so much to memory when the information is right here in the book. Just understand where in the book or knowing where in the book to go. So, chapter 12 begins with the guidelines for the integumentary system or diseases of the skin and subcutaneous tissue. And I so hate looking at these pictures, especially when I have food in front of me. um, because I'll just say, let me just skip past it. Um, but chapter 12 talks again about diseases of the skin and subcutaneous tissue. Specifically with this chapter, there's a lot of mention of pressure ulcers. And so with pressure ulcers, they are coded according to a couple of things. They're coded according to the location of the ulcer in someone's skin and also the stage of the ulcer. So it could be a stage 1, stage 2, depending on how deep it is, how large it is. If it just goes down to the through the skin, down to the muscle tissue, or even down to the bone. So um, there's a lot of detail involved in those codes as well, which would, result in having a lengthier code, maybe not just 3 characters, but up to 6 or 7 characters, just so all of this detail can get in. And that, again, that is that they're classified by the stage based on the severity designated by stages 1 through 4. And then you have deep tissue pressure injury, and they could also be an unspecified stage or unstageable. Um, so let's first talk about pressure ulcers that are unstageable. And I'm on page G18 of the guidelines. So guideline 12A, 12.A.2 on page G18 talks about unstageable pressure ulcers. And when they're unstageable, this means that they do not equate, it's not the same as unspecified, because unspecified means that the doctor mentioned that the patient had an ulcer, he just didn't tell us what stage it is. If it's unstageable, that means that the doctor himself is not able to clinically make a determination of what stage the ulcer is. So again, it's not the same as unspecified. Unspecified is when the doctor knows the stage and he just didn't tell us in his note. But unstageable means that it was so bad, maybe it was so bad, or he just did not have the equipment to properly examine the patient to determine what the stage is. That makes sense to everybody? Okay, cool. So highlight that guideline. My rule of thumb is if it's mentioned in the presentation, then it's something they're going to want you to remember later. So here's an example. A patient is treated for a pressure ulcer of the ankle, and the diagnosis code here is used to code according to what this example says. So all the example says is the patient is treated for a pressure ulcer of the ankle. It's not telling us what stage. It's not telling us if it's a deep, ulcer. It just says ulcer. So this would be considered unspecified because the documentation in our example did not give a stage. Now in this example, it says a patient is treated for an unstageable pressure ulcer of the left buttock. So the code here, L89.320, represents pressure ulcer of the left buttock unstageable because that was the description that was given. He examined the patient, he looked at the ulcer, he wasn't able to determine a stage based on the way it looked, based on, maybe it was skin growth, maybe it was no skin at all, maybe he just couldn't access it because, and this happens actually a lot with patients that are bedridden. If they can't, maybe he couldn't even get to the ulcer. Like if they have a patient that is heavy, like morbidly obese, and let's just say a 500-pound patient, right? They have to have the proper equipment to move this patient. First off, they have to hoist them up on, um, I forget what the machine is called. It's probably called a hoist. But anyway, um, they have to use that to pick them up or maneuver the patient, and they have to have a lift team. So if they don't have all of that, then they can't really make a determination of the stage of the ulcer. So unstageable is what they stated, and unstageable is how we code it. So if you go to real quick to the alphabetic index to ulcer, and don't and hold down your guideline page because we're going to go back there. But I just want to kind of let you see what it looks like in the alphabetic index because this is a significantly large section because when you talk about ulcers, they, in our skin covers our whole body, so an ulcer could literally be anywhere.
What page is that?
348.
Okay. All right, got it.
Looking for
All right. So on page
unstageable
348,
ulcer.
um, just looking at the header of ulcer, you can see, it covers almost all of page 348, 349,
Hmm.
page 350, and a little bit of page 351. So a lot of descriptive descriptions of types of ulcers. So specifically, let's, look at the example patient is treated for a pressure ulcer of the ankle.
Hmm.
So
Okay.
let me fix my eyes. Oh, I see it. Ulcer. So if you're following along with the alphabetical order and the indentions, we have to remember anatomical locations, right? Anatomy. So the ankle is a part of the lower limb. So while you may think that you just could have gone to ulcer and looked for ankle and maybe seen it like right there listed first, it's not because it's listed under lower limb. Um,
Okay. Unspecified now, that's the part.
yeah, I'm just making sure I'm looking through, making sure I see what I need my eyes to see because it's a lot, and I don't have a magnifying glass right now.
Unspecified. Lower limb, unspecified.
Oh,
MEC.
One sec. Okay. So, and this is just because my eyes are focusing in on the book, and this is a new book, and they make changes to the book every year. So we are correct in being under ulcer, but instead of going to lower limb, I want us to go to pressure because a pressure ulcer is a specific type of ulcer. So look on page 350. Sorry about that. On page 350, in that first column, near just a little bit past halfway point, you see the distinction of pressure under ulcers. So this is where your pressure ulcers lie. And under pressure, we immediately see ankle. So if our code is, we know the code based off the PowerPoint slide is L89.509. So we see that we have the start of the code right there. We have ankle with L89.5 and the check mark. Everybody see that on page 350?
Yes.
Yeah. Yes.
Cool. So now you would have to go to the the tabular list, L89.5. So let's follow it along so we can. And I'm doing this just again so you can kind of become familiar with this section. But we got plenty of sections. L89 point
Five.
Okay.
which is on page 772. L89.5. Okay. So it's the pressure ulcer of unspecified ankle because the example didn't specify whether it was right or left, correct?
Correct.
All right. So we know already that unspecified stage. So look at L89. I mean, you can look at the other ones too, but you can see there's a distinction. So um,
I see
L89
what I said.
got 500 is unstageable. That doesn't fit. 501 is stage one. L89.502 is stage two. L89.503 is stage three. So you kind of can see a pattern with the last digit of the diagnosis, right? L89.504 is stage four, but we're looking for unspecified ankle, unspecified stage. And if you look at L89.509, that confirms it. So you're not always going to see a full code in the alphabetic index. You're going to have to go to the tabular to finish building your code. As long as you know you're under the proper heading, like when you're in the alphabetic index, like how we had to go to pressure ulcer in order to find our listings, um, then you'll be along the right track with these.
Fresh.
And if when you're doing your assignments you get kind of stumped on this, then you can just play back the recording and pause on that section so you can get it. And then again, if we did the same thing with L89.20 in the tabular list, you'd also see the same type of options and listing for pressure ulcer of the left buttock that would be unstageable. So let's talk again or some more about pressure ulcers and the assignment of how the assignment of the stage should be guided by clinical documentation. That means you or me as a coder, we cannot make a decision to say, oh, this was a stage 1 or this was a stage 2. It has to be documented. Even in your questions, it has to state, um, it has to give you an assignment of the stage. Even if that assignment is unspecified or unstageable, at least you know you have something to be able to select a code by. So no guessing games with the stages. It either says a stage, it says unspecified or unstageable. Um, when somebody is admitted to the hospital and they go in, say with a pressure ulcer, but then that ulcer heals over time while they're in the hospital. So let me go back to the guidelines. Sorry. So guideline 2 was the unstageable. Um, and then on G19, guideline 3, documented pressure ulcer stage, is the one that we just talked about where we can't, as coders, make the determination, but it has to be clinically documented. Guideline 4, patients admitted with pressure ulcers documented as healed. So no code is assigned if the documentation states that the pressure ulcer is completely healed at the time of admission. So if the pressure ulcer is completely healed at the time that the patient is admitted, then we don't code anything because they no longer have an ulcer. Um, Now, on the flip side of that, in guideline 5, if that patient um, pressure ulcer is documented as healing, so if it is documented or described as healing, healing. Ulcers described as healing should be assigned the appropriate pressure ulcer stage code based on the documentation in the medical record. If the documentation does not provide information about the stage of the healing pressure ulcer, assign the appropriate code for unspecified stage. So I would just highlight that for now and just kind of hold on to that guideline by highlighting it. Let's look at number 6 because that's the one referenced in the slide here. And it says that if a patient is admitted to an inpatient hospital with a pressure ulcer, wait, am I reading the right one? Hold on. Okay. Um, Sorry, I got 5 and 6 mixed up. 5 is the one that's on the slide right now. Um, yep, 5 is the one on the slide right now. So I'll go back over that to finish that last part in number 5, the second paragraph where it says if the documentation is unclear as to whether the patient has a current or new pressure ulcer, or if the patient is being treated for a healing pressure ulcer, query the doctor. Querying the doctor is a process that we use in the facility, in the hospital, when the doctor does not have enough information in his record for us to code a case accurately. So we query them, meaning we question them. Like, hey, we need you to update your documentation so that we can accurately code this. And I'll run through these, but we'll look at some more examples. Patient admitted with ulcers documented as healing. For ulcers that were present on admission but healed at the time of discharge, assign the code for the site and stage of the pressure ulcer at the time of admission. That is guideline 6. Um, no, it's not. It's 5. I'm sorry, y'all. Where are my glasses? I need my glasses because I can't see. need additional light. Let me put my let me turn my supermodel light on. Make it brighter. Okay. This will help me. I'm sorry. Am I confusing y'all? Because I feel like I am.
Yes, I'm a little lost.
Huh?
I said, yes, I'm a little lost. I'll
Okay.
admit.
Well,
Yeah,
thank you.
I'm
Thank you
having,
for admitting.
well, I'm having a hard time finding where you are.
Let me just get my light. I think one of the light bulbs on my ceiling fan is also out. Okay. Let me see if I can fix that too while I'm.
Yeah.
Because I ain't no good if I can't see.
Yep.
Okay. Let's just back it up. Let me back it up a little bit. Documented pressure ulcer stage. We got that one. That was guideline 3. Patients admitted with pressure ulcers documented as healing is guideline 5 on page G19. So just highlight it. I won't reread it, but I do want you to highlight it, and I'm just going back to make sure we know which guideline was which. Patients admitted with pressure ulcers documented as healing. Patients admitted with pressure ulcers documented as healing is guideline 5, where it should be assigned the appropriate stage based on documentation in the record. And then patients admitted with pressure ulcers evolving into another stage during the admission is guideline 6. This one specifically states that if a patient presents or is admitted with a pressure ulcer at one stage and then it then progresses to a higher stage, like if it started at a stage 1 but maybe they were again a bedridden patient and they were sitting in this position and it just continued to get worse, then the guideline states that you should assign 2 separate codes, one code for the site and stage of the ulcer on admission, and then a second code for the same ulcer site in the highest stage reported during the stay. Because the highest stage is going to determine medical necessity for any testing or procedures that they're going to do to treat that ulcer. That makes sense? Okay, cool. Documentation for BMI and pressure ulcer stages. So again, because this is something that you will see with patients that tend to be morbidly obese, patients that may be in a coma, so the coma scale would kind of come into play. So guidelines indicate that for either BMI, which is body mass index, which if a patient is over, I think it's 35% of a fat composition in their BMI, that they're considered obese, and then anything over 40% is morbidly obese. I think that's how it goes. But anyway, non-pressure ulcer or pressure ulcer stage codes, the code assignment can be based on the medical record documentation from clinicians who are not the patient's provider, meaning that, um, maybe a hospitalist or a cardiologist or a nephrologist, if the patient has hypertension, end stage renal disease, diabetes, and pressure ulcers, any one of those doctors can um, document that the patient has a high BMI and that may have contributed to their pressure ulcers. So the BMI, coma scale, and NIHHS codes should only be reported as secondary diagnoses, but anytime it's a pressure ulcer related, the pressure ulcer will be coded first. So that's chapter 12. More practice to come with that, but I do have 9 more guideline chapters to get through, and I think we can definitely do it in an hour. So chapter 13 is diseases of the musculoskeletal system and connective tissue. Biggest thing here with these guidelines is simply laterality, and making sure that in your diagnosis coding, you identify whether the injury or musculoskeletal condition is related to the left side of the body or the right side. Like if it's a knee, is it the left or right knee? If it's a elbow, left or right elbow, hand, shoulder, foot, ankle, etc. Um, and that is actually the first guideline on page G19, site and laterality. That should always be um, a part of the code. And they actually do in some of the sections of chapter 13 guidelines, which these are some of the diagnosis codes, they all start with the letter, right? So M is related to musculoskeletal. All of the chapters aren't like that, but this particular one is with these sets of diagnosis codes, just like you'll see in a little bit that O, well, the N codes, excuse me, LMN. So N refers to like the kidney conditions like nephrology. O refers to obstetrics and OBGYN related things. P, all of the diagnosis codes that start with P are for pediatrics. Elemental P, Q. The Q codes are for like congenital anomalies or birth defects. I'll stop there because the R's don't make any sense. It's just like, with the skins, why did they pick L for all of the skin conditions? Makes no sense to me. If it was me, I would have created all the diagnosis codes that start with the letter of the thing that they are related to. But anyways, back to chapter 13 guidelines. This slide is just an example of that very first guideline under 13A that talks about site and laterality and making sure that there's a clear understanding of why that's important. Also, 13.A.1, bone versus joint, makes mention that for certain condition, the bone may be affected at the upper or lower end. So the site designation will be the bone and not the joint. So this is again another one of those sections where anatomy comes into play in a huge way. But remember, you got your anatomic diagrams in the front of this book as well, near the guidelines. So you don't have to memorize all your bones. If you want to, you can. Um, it will certainly be helpful, but you don't have to because you can just look at one of the diagrams. So, like, for example, how it's saying the site designation will be the bone and not the joint. So, versus saying the knee in some examples, it would say the patella, which is the bone on the front of the knee, versus saying the collarbone or shoulder girdle, or collar, it would reference the clavicle, which is that bone that's right here. That is the collarbone. It would reference the clavicle. So the designation would be you would code to the bone and not to the joint. Next guideline, acute traumatic versus chronic or recurrent musculoskeletal conditions. Um, So because these guidelines also relate to Chapter 19, I'm going to skip this because Chapter 19 diagnosis codes really talk more about traumatic and chronic injuries. But just also know that there's a reference here in Chapter 13 as well because it's related to the bone and joint. Coding of pathologic fractures. So a pathologic fracture, you have your traumatic fractures, which is the breaking of a bone that may happen in a traumatic way, like, getting hit by a car, fell off the house, uh, something random like that, some type of accident. But a pathologic fracture is a fracture that is caused due to another underlying condition. Um, like, say, for example, if someone has osteoporosis, one of the main symptoms or issues with that condition is that it causes frequent fractures because your bones are so brittle and don't have the density that they used to because of the lack of calcium. So, a pathologic fracture can be caused, that would be an example of a pathologic fracture. Also, if someone has, say, bone cancer, a type of bone cancer that may also eat away at their bones to the point to where it'll cause the bones to fracture again because they're brittle, or a cancer can actually just eat a hole through bones. So that would be another example of a pathologic fracture. Like someone with osteoporosis could just be, and oh no, how did you break your leg? I was just walking, just regular walking. But it wasn't the trauma of walking that caused the fracture. It was the osteoporosis um, that caused the fracture. So with pathologic fractures, there is, when you go to, and I'm going to have to show y'all this as well. Two of the largest chapters or sections in your alphabetic index are going to be fractures and pregnancy. So right now, let's go to fracture. Because like ulcers, it's going to take some getting used to with your eyes. Oops. Okay. Fracture you can find starting on page 186, actually. Bottom of page 186. But it goes to page. That can't be right. Yeah. It goes to page 192. That's a lot of tiny little words and letters, ain't it?
Yep.
Yeah. Right.
That's why I need an extra light. um, but yeah, and also, so highlighters, get your highlighters, and I want y'all to, and I'm doing it too because I'm going to need to use this book again as well to take my exam. I told y'all I never took that exam, right?
Mm-hmm.
Yeah.
So yeah, I have to reschedule it.
You needed to.
I gotta tell y'all, the stress of getting to these exams on time. Oh, that's why I do mine at 9 o'clock and not 8 o'clock. Some people do their exams at 7:30. That is just entirely too early for my brain to start functioning in that manner. All right, so take your highlighters, and the only thing that I want y'all to do, if you can see, let's see if I can put this up close. Just highlight on in each column the word fracture. The only reason I did that is so that when you're looking in this section, you can see that there's more columns of fracture that I need to look at. If you're looking for something particular, since it's so large, and we're going to do the same thing eventually when we get to pregnancy too. because it's separated by a number of things, but you have dental fractures, traumatic fractures, non-traumatic, pathologic fractures, um, fractures due to cancer. I'm just calling out random things. I'm not calling them in the order they're listed. Um, so you'll get some stress fractures. That's another one. Um, really knowing the anatomy helps. So just to remind you about your bone anatomy, um, pages. Skeleton. Okay. Ooh. Oh, here we go. Like these pages back up front.
Mm-hmm.
Yeah. And you got all your bones laid out for you in some shape, form, or fashion, in the anatomical structures. So, in illustrations. So you won't be lost there. Just know that, there's multiple places in your books, not just this book, but also the CPT and the other one that we haven't even explored yet. So, fractures is one thing. It talks again about osteoporosis and what it is. That is a systematic condition that is caused due to a lack of calcium in the body, which tends to happen to women as we get older and go through menopause. Um, and those osteoporosis can either be with or without a pathological fracture. So again, you'll just have to pay attention to the type of fracture that you're coding. So some of these slides I'm just going to kind of run through just because, for the sake of time. But back to the guidelines. So specifically, these are the guidelines that I want you to highlight in chapter 13, page G19. I know I'm taking y'all all over the place and I'm sorry. But on page G19, under chapter 13 guidelines, highlight the guideline for coding of pathologic fractures. That's guideline C. Then also highlight D1 and D2 under osteoporosis. One is how to code it without a pathological fracture, and the other one is coding osteoporosis with a current pathological fracture. And guess what? That's all of chapter 13 guidelines. Biggest thing, like I said, is that laterality, making sure you're identifying the left or the right in your diagnosis coding. Chapter 14 guidelines, however, can get a little bit sticky, but it is only one set of specifics in this chapter, and it's related to chronic kidney disease. So chapter 14 guidelines are diseases of the genital urinary system. The codes are N00 to N99. So a lot of codes, considering that is all related to either chronic kidney disease, chronic disease with a kidney transplant, or chronic kidney disease with other conditions. And I don't know why it was so hard for me to say that just now. Um, but yeah, basically with these is first thing, understanding the stages of chronic kidney disease. I should just say CKD. Understanding the stages of CKD. And the stages are classified based on their severity. So someone maybe with stage 2 may not be a prime candidate for dialysis, but someone with stage 3 or higher, which is moderate CKD, may be a candidate for dialysis. So here it gives you on this slide, which you can also see in guideline number 1, stages of CKD on page G20, and it gives you the stages and the codes of what they equate to. Ultimately, you could either be a stage 2, a 3, a stage 3A, which is based on the glomerular filtration rate. So this is all determined by labs that would have to be done, and they literally just they can draw blood and determine a patient's need or stage of CKD. Stage 3B is also based on that filtration rate. And then you have stage 4, which is equating to severe CKD. So notice that, again, that character after the decimal point relates to the stage. So stage 2 would be N18.2. Stage 3, N18.3. 3A and 3B have an additional character just for that primary distinction to determine what is A and what's B. Then stage 4 is N18.4. Stage 5 is N18.5. And then end stage renal disease. So this is at the point to where, someone would be in need of a kidney transplant. If they're at end stage renal disease, which is greater than stage 5, then they are at N18.6.
Well,
And that's also all available to you in guideline 14.A.1. So now looking at the next guideline, number 2, chronic kidney disease and kidney transplant status. So for patients who have undergone a transplant, they may still have some form of CKD because their body is trying to restore function. I know 2 people recently here that were able to get kidney transplants from MUSC. Two young guys actually. Well, young as in my age or younger, mid 30s or so. Um, but even though they had new kidneys, they still had to do dialysis for a little while just so their bodies could adjust to the kidneys functioning. Um, so that guideline specifically says they may still have some form of CKD because the kidney transplant may not fully restore kidney function. So you must query the provider before assigning additional codes for CKD for that reason. Chances are you won't have an example of that in a testing environment because I very rarely see it in a real life environment, but just be aware and familiar with the guideline. And then the last one for patients with chronic kidney disease and other conditions. So other conditions would be those conditions that we talked about back when we did chapter 9, guidelines for the circulatory system, as well as um, chapter 4's guidelines for the endocrine and metabolic system. So if they have hypertension, chronic kidney disease, congestive heart failure, then this guideline just specifically reminds us that, patients with CKD may also suffer from other serious conditions, most commonly diabetes and hypertension, because those 2 conditions can cause kidney disease. So the sequencing of the CKD code in relationship to codes for other contributing conditions is based on the conventions in the tabular list. So the tabular list and the guidelines always match and correlate together. So you would want to reference if you have questions about CKD and how to sequence it with other conditions, then your target point or reference point should be chapter 9's guidelines. If it's hypertension or diabetes. Quick example. Well, you know what? We haven't talked about Z codes in detail yet, but that's that status code. So you know what? I'm gonna save this example. But in this, I'll just say real quick. In this example, a patient is coming in because they have end-stage renal disease and they're getting prepped for dialysis. So the only reason is that for this encounter is that they're coming in for a dialysis catheter. So we would first use this Z code as a encounter for because that's the reason for the visit, and then secondly the N18.6 to add the diagnosis for the dialysis. But that's not really going to make full sense until we talked about chapter 21 guidelines, and we got a ways to go. So chapter 15 guidelines, page G20 as well. There are a lot of pregnancy guidelines, a lot. So obviously I won't be able to talk about all of them tonight. And you will get some practice, but please get your highlighter out again. And before we get into the guideline, let's go to the tabular list. I'm sorry. Let's go to the alphabetic index to pregnancy.
Jesus.
Page 291. Everybody got it?
Yeah.
Yes.
Okay. On page 291, you can see the start of the pregnancy section. And that goes from 291 to
It's a lot.
290. Yeah, it is a lot. It's 292 to 295. So it's a bit of pages. So what I want y'all to highlight is, how did I do mine? Where's my pen go? Same way we did fractures. So highlight on 291 just the word pregnancy at the header of it. And then also I want you to highlight. Go down just a little bit. Y'all see where it says complicated by?
What was that?
Pregnancy and then complicated by?
Mm-hmm.
Oh,
291 as well. You see it?
Yes.
Everybody else got it?
Mm-hmm.
Okay. Reason I wanted you to highlight complicated by is because that is the start of a huge long list of all types of possible pregnancy complications, A to Z. So it starts on that page 291, complicated by abnormal cervix, abnormal cord, fetal findings, complicated by glucose. It just, the list goes on. So turn to the next page, 292. And see at the top under pregnancy, again, it has complicated by. So highlight complicated by in each of those three columns, just so you know that that still is a continuation of the pregnancy complications. And same for the next page on page 293, because that is also a continuation of pregnancy complications, because it's literally listing all possible complications from A to Z. Pregnancy complicated by, so on page 294, there's that first column is the last one of the complicated by list. So notice under that one it has complicated by viral diseases, complicated by very young mothers. So they don't leave anything, any stones unturned. Complicated by vomiting, complicated by uh, let's see, ectopic. Well, no, that's under another heading. Complicated because we're under the V. So complicated by TUVY. Okay, cool. So complicated by ends with young mother. Because I'm looking at the indentions. Y'all see that?
Yes.
Complicated by ends with young mother. Then after complicated by, there's concealed, continuing. Um, I just saw something else. Oh, see ectopic pregnancy. Highlight that. Highlight ectopic because that's another heading. Not definitely not as long as complicated by, but you know it has ectopic with abdominal, ectopic with cervical, complicated by, etc. So those are all ectopic pregnancy related. Now I want you to highlight one more thing. See at the end where it says weeks of gestation.
Yes.
Third column. Okay. So those codes are all. Well, let me rephrase.
CC codes.
Anytime, yes. So anytime you code a diagnosis that starts with the letter O, which is one of the pregnancy codes, you're going to follow it with the Z code. You have to follow it with a code that represents how many weeks the patient is. So if the patient is um, coming in for, I could just pick something at random. Let's see there. Okay, preterm labor, which is an O code. I don't know what the code is off the top of my head. But if they come in for preterm labor, then we have to add, let's say it's preterm labor at 30 weeks. So you'll code your first code of the O code, and then your second code would be Z3A.30, and that would represent the 30 weeks. So for the most part, these Z codes are going to correlate to the weeks, the actual weeks of the gestation. But notice when you get down to, my God, 42 weeks, y'all. Can
Yeah.
you imagine carrying a human for 42 weeks?
Mm.
um, so it has 42 weeks, and that's Z3A.42, and then you have greater than 42 weeks, less than 8 weeks, and not specified. So those last three are, just kind of there as other layers of coding if the weeks of gestation is not either specified or if it's just less than what's included in this list. So I wanted y'all to highlight that list because you're always going to have to code that if you code an O code. Now let's hit the guidelines. Trimesters are defined as follows, and y'all may want to write this down because I'm not sure if it's anywhere in the guidelines specifically. That trimesters are, or maybe you know already, but I don't hold anything to my memory at this age, this ripe age of 45. Um, so the first trimester is less than 14 weeks or 0 days. Second trimester is 14 weeks, 0 days to less than 28 weeks.
Oh, excuse me.
Then the third, bless you, is 28 weeks to delivery. Excuse me.
Second. 14 weeks.
And eight.
4 days. To less than 28 weeks. 28 weeks.
Third.
Got it?
It's 0 days until delivery.
They make it so complicated in their descriptions. Second trimester is 14 to 28 in 0 days, and then third is 28 to delivery.
Okay.
And these are chapter 15 guidelines. So versus going, but there are a few that I definitely want to talk about. Let's see where the slides take me. So I've already talked about weeks of gestation. That is a very important guideline. It's for y'all to remember. Um, Here's an example. So, a visual of what I was trying to share. A woman at 16 weeks, 2 days of her pregnancy presents to her OBGYN for hemorrhoids. So there's a diagnosis that is hemorrhoids in pregnancy, second trimester, which if you were searching for that in the index, it would be pregnancy complicated by hemorrhoids. And that code is O, not zero, but O, 22.42. And then because she's 16 weeks, then you would report the Z3A.16. So it's just they should come in a pair. So the first code will tell the condition, but the second code will tell what the trimester is. And you certainly can have multiple complications, which would mean multiple codes. But just for now, kind of keeping it simple. Codes from chapter 15, the pregnancy codes, when it comes to sequencing, these codes have priority over codes from other chapters. There's one exception, but these codes are always to be listed first. O codes. They have priority, sequencing priority over codes from other chapters. And that is because if someone has other conditions, it's always going to be pregnancy complicated by making it that O code, just like we saw with the hemorrhoids. Because there is a code for hemorrhoids, right? But
Yes.
because this is hemorrhoids in pregnancy, we have to have that O code from the pregnancy section. And these codes are to only be used on the mom because there's a whole nother section of codes that would only be used for the fetus or for the baby. It would be for the baby, not fetus, because it starts from age 0 to 28 days. So I'll take that back. But these O codes are to only be used for the mother. The final character for the trimester in your diagnosis coding, as you're building your code, like when you go to your tabular list, you'll see that the final character in your code is typically going to be used for to identify the trimester. However, your Z code, that second code that you add, is going to be used to further detail the weeks of gestation. So just a piece of information to have for you there. If a patient is admitted to the hospital for complications of pregnancy and remains in the hospital for an extended period of time, like, say high risk pregnancy, someone's water breaks, at 27 weeks, and they just stay in the hospital for that entire time until they're able to give birth. It's possible for complications to develop during different trimesters. So the antepartum, which is during the pregnancy, complication code should be assigned on the basis of the trimester when it actually started. So same example, someone at 27 weeks and their water breaks, and then they say, okay, well, we're going to put you on bed rest, then you will continue to use that particular diagnosis code um, with the trimester that the complication took place. So if it was at 27 weeks, that would be the second trimester. And the third one starts at 28 weeks. Um, go to page G21 for me so I can have y'all highlight some of those guidelines specifically.
Yeah.
Um, all right, let me hit this first because this is more of a convention than a guideline. And conventions apply to is general coding. So, the fetal extensions, it says when applicable, a seventh character is to be assigned for certain categories to identify the fetus for which the complication code applies. That is going to be for single gestations, meaning one baby, one pregnancy. The seventh character would be 0, but it may be different if there's a twin pregnancy or a triplet pregnancy or quadruplets. Um, all the way up to octomom status. I don't know that people are having 8 babies at one time anymore, like octomom was, but they probably had to create a new diagnosis code just for that situation, right?
Yeah.
But um, the seventh character is going to be dependent on the number of gestations. So this next couple of things are actual guidelines. So guideline number the one we just talked about, by the way, was 15A dot 6. So you can highlight that one. 15A dot 6. But also highlight 15A dot 1, 2, 3, because those are going to be ones you'll want to reference back to. Um, now we're going to,
Oh, can you repeat that again?
sure,
Oh,
15A dot 1
okay.
dot 2 dot 3 and dot 6, number 6, seventh character for the fetus.
Thank you.
You're welcome. Now look at 15B. So this whole section is relating to selection of the principal or first listed diagnosis. So these guidelines are going to be extremely helpful to you. The first one, number 1, is for routine outpatient prenatal visits. So this is healthy pregnancy, no complications are present. Patient goes in, monthly for their prenatal visit. For those encounters, you're going to use a diagnosis of a first listed diagnosis of from the Z34 category. So it could be Z34.00. I think for first pregnancy, Z34.01. For pregnancy, another category, but it would definitely come from that Z34. And these again are to be used for routine outpatient prenatal visits when no complications are present. So when we go to chapter 21 with the Z codes. Some of those Z codes can be used as principal diagnosis, only a select group, and then others are simply just status codes, like we've kind of talked about in the past weeks. Um, outcome of delivery, which is number 5 under B5. Did I skip one? I did. But I'll do outcome of delivery since mine is already there. Whenever a baby is born, and this should be coded on the mother's record that she delivered. So when she delivers, a diagnosis code, a Z37, or from the Z37 category. And I would keep saying that because I can memorize these codes just because those codes have been the same forever, for at least the past 20 years. So, like, if it's a single live born, it's Z37.0. There's a code for a single live born and stillborn. Then there's this code for twin live born with both, or twin, both live born, twin, one live born, one stillborn. Like there really are codes to designate any possible status or possible outcome. That's guideline 5. And then going back to prenatal outpatient visits for high risk patients, which is guideline B.2, it says that you should report a code from the O09 category. Now, again, all of these I don't expect you to remember because honestly, if you follow the alphabetic index, it's going to take you to the category of codes that you need. But in case you need a reference point to say, okay, I don't know if I selected the right code, then you want to come back to the guideline. But also remember that your guideline and your tabular list match. They're the same. It will give you the same information if you go to either. Um, while I also remember this, if y'all take a look at so sorry. Page 781. So I know we talked about this when we were tabbing our book. I don't want to forget to make frequent mention of the fact that all of your anatomy and medical terminology related questions can always be answered by going to the tabular list. Always. So on page 781 in the back of the tabular, this is the start of your oh, that is the wrong section. I'm sorry. I'm supposed to be going.
Yeah.
Anyway, for the musculoskeletal system,
Uh-huh.
page 781 would be the go-to place. But for the obstetrics or pregnancy, childbirth, page 901, that's where I wanted y'all to go. Sorry. I didn't eat much today. I probably should have I didn't eat lunch today because I had a radio interview that I was sharing before everybody got on. So I spent my lunch period on the radio, which was really fun and exciting today. But I feel like I gave that all my energy to that. I had nothing left, and I didn't put anything in me since then. So, anyways, page 901 is where you have your anatomy, your medical terminology. So don't forget about this when you get to that section and you're sitting down and even, as you're going through your homework with your diagnosis coding, you may need to reference back to your anatomy and your terminology. So just remember that it's here in this section where you have the introduction and you got the anatomy of the female reproductive system. And then you have even further breakdown. So like just on page 901 real quick, for number 1 you have the female reproductive system includes the following. So if you had a question of which one of these organs is not a part of the female reproductive system, that's going to be your point to find your answer to that question. Um, Number two is the anatomy and structure components of the reproductive system is further described below, so it then gives a further breakdown of the ovaries, the uterine, the fallopian tubes, the uterus, the vagina, the external genitalia, um, the perineum, the menstrual cycle. So it breaks all of that up for you. Even if it was, I mean, granted, we're females, so we should know the steps of the menstrual cycle. Um, but there's a really good breakdown right there. So if you were asked a question about it, you don't have to rely on what you know. You just need to know that, hey, I can go to page 901 and all the answers that I need is right there. But I wanted y'all to also notice one thing that hopefully it may have sunk in by now, but just in case, to show the correlation between the chapters, the tabular list, and the guidelines. Excuse me. So the tabular list on that purple edge of page 901, where it says chapter 15, pregnancy, childbirth, and the period, and it also says that at the top of the page.
Yeah.
So again, if you go back to your guidelines, that's how you know that the tabular and the guidelines they're twins, really.
Mm.
Everything you find in the tabular is going to be in the guidelines. Everything you find in the guidelines is going to be in the tabular. Um, Other pregnancy pre-existing hypertension in pregnancy and pre-existing conditions versus conditions that are due to the pregnancy. So like, make sure that's not something we're going to talk about. Gestational diabetes, um, or diabetes period, um, will be an example of, it could be pre-existing or it could be due to the pregnancy. But how it's listed will determine how you code it, how it's documented by the doctor. And then hypertension, pre-existing hypertension as well, same thing. It could be pre-existing or it could be due to the pregnancy. Um, and also could be a cause of, don't tell me, preeclampsia, which there's a specific guideline for that as well. So what to highlight? Under B, highlight prenatal visits, number one. Highlight also um, guideline number B2. Highlight B3. Oh, and 5. Now, pre-existing conditions, it's first going to be important for us to know if the condition was pre-existing or if it developed during pregnancy. So for pre-existing hypertension complicating pregnancy and childbirth, we report a code from O10. So remember, regular hypertension is I10, right? So the pregnancy or hypertension complicating the pregnancy, which is if it's pre-existing, we would code a category from O10 versus I10. But the correlation there is the number 10, for the hypertension. So hopefully that'll be something that'll stick with you and be a helpful reminder that I10 is regular hypertension or hypertension without pregnancy. O10 is pre-existing hypertension in pregnancy. I like to use the word regular loosely, like there's no such thing as regular hypertension. um Codes from category O35 and O36. Just highlight that one in your book. I'm not going to spend time talking about that one because I need to talk about HIV in pregnancy. So during pregnancy, the HIV guideline, which is F under Chapter 15, it says during pregnancy, a patient admitted because of an HIV related illness should receive a principal diagnosis from subcategory 098.7. So that goes against the Chapter 1 guideline, right? That says we should report B20. So, and that is because this is a pregnancy, so we have to have the O code for that HIV. So that this is the only exception to that B20 rule. The only exception. So I'll leave this here just long enough for you to be able to visualize the slide if you need to pause it as you're watching the video. And we're going to go to the next slide because I'm trying to preserve our time a little bit because it is 8:23. And I already see that I'm going to have to kind of split this up because we're just at chapter 15 guidelines and we still got 6 more to go. So what I'll do is um, I'll get through 15 and then I'll work on first thing tomorrow morning or tomorrow at my lunchtime. I'll record the remainder of chapter 15 and I'll have both of those recordings available to y'all no later than first thing Thursday morning, if that's okay, or tomorrow night.
Yeah, that's good.
Thursday night, okay.
Yes.
So chapter 15, diabetes in pregnancy. Pregnant women who are diabetic should be assigned a code from 024.0 to 024.3 and followed by the appropriate diabetes code from category E. So this is unique because with some of the other pregnancy complications, you only needed the O code and the weeks of gestation. But this one is telling you to code the O code for the complication. Secondly, the E code to represent the type of diabetes. And thirdly, you would still need to report the weeks of gestation Z code. That is guideline G on page G21. Now, if the patient, going on to this next guideline, which is H, guideline H, if the patient is taking insulin or any type of oral hypoglycemics like metformin, then you would reference, it says C section and it's giving you the guideline to go to. And that is because that guideline is the one that tells you what Z code to use for which medication, whether it's insulin or if it is metformin. And remember, there's also a shortcut to that, which I'll remind y'all of in a little bit. Actually, that shortcut to finding those Z codes for the long-term use of drugs is on page 1317. So the Z code one would represent a hypoglycemic drug. That is Z79.84. And then the other would represent insulin. Sepsis during pregnancy, or sepsis and septic shock complicating abortion, pregnancy, childbirth, and the period, which is the period of the pregnancy itself. So sometimes when someone is having, has a miscarriage or what they like to call retained products of conception, like maybe they didn't pass all of the placenta or something like that, and some components of either the pregnancy or blood tissue remained in the person's body, and that in turn caused an infection, which sepsis or septic shock, that is life threatening, just like we learned about sepsis. So um, there are specific guidelines for that that actually are very similar to what we saw in chapter 1 for the sepsis guidelines. So when coding sepsis for pregnancy, a code for the specific type of infection should be assigned as an additional diagnosis. So your first code will be the O code, and then the second would be second part of that guideline is when severe sepsis is present. Code R65.2 severe sepsis and codes for associated organ dysfunction. So like if it was, kidney failure, respiratory failure, whatever organ dysfunction there was, you would code those additional codes. So basically just kind of following the guideline there, and that is guideline J and K. On page G22, um, 'cause there's a lot more guidelines with pregnancy, but on page G22, there's one of those tables that we all probably aren't great fans of. If you find it easy to use the table, you are more than welcome to use it because it'll save you time from reading the guidelines individually. Um, and if you struggle with reading the table, I would just probably recommend just kind of looking at it, over and over again. There are some really great YouTube videos that I'll try to find for y'all that'll help kind of break, particularly this section down, just because it's so large. Um, and I knew that this one was going to take, a little bit longer than we typically do. But I don't want to take a whole nother week because next week we'll start surgery coding, which is why I'll just record a two-part video for this. Um, but additional pregnancy guidelines. So we got alcohol use, tobacco use, and drug use during pregnancy. Um, just go ahead and highlight those guidelines. I think once you read them, they'll be pretty clear to understand. Um, Notice that the guideline says use and not abuse. So alcohol, tobacco, and drug use. And you can kind of read over those guidelines. Next, the encounter for full term uncomplicated delivery. So if a person is coming in specifically just to deliver, um, that is where a normal delivery. So this is talking normal, uncomplicated. Then you would go to guideline N as in Nancy on page G22. Is only to be used when a woman is admitted for a full term normal delivery and delivers a single healthy infant without any complication antepartum during the delivery or postnatal during the delivery episode. Peripartum and postpartum period. So postpartum is defined as 6 weeks following delivery. The peripartum period is defined as the last month of pregnancy to 5 months postpartum. You typically don't hear people say peripartum. It's just not a normal part of conversation ever. Postpartum is the main thing, and we all know that is a 6 week period. So I hate that tonight was not as exciting as some of our other nights just because we kind of really had to get through a lot of these guidelines. But this one, abuse in pregnancy. Three codes. You got 098.3 requiring additional character for physical abuse. .4 for sexual abuse. And .5 for psychological abuse. These are all complicating pregnancy. So they would just need the additional characters to complete the code. And this is R. Guideline R. Um, I would be remiss if I did not mention guideline Q as well for one to highlight. Guideline Q is termination of pregnancy and spontaneous abortion. So whether it's a miscarriage, um, a sought out abortion, or of willful termination of pregnancy, or what they call a spontaneous or incomplete abortion would be one where someone has a miscarriage and they don't pass all of the pregnancy. They retain um, what they call products of conception. So read through that guideline. It's pretty self-explanatory, but it just kind of explains and further defines how the term abortion is utilized. And I'm wondering if they'll even make changes to that, going forward with the laws that were recently passed in the upcoming year or two. And then the last guideline for pregnancy is guideline S, as in Sam. I promise y'all, this is the only chapter that has this many guidelines. But that's because there's so many possibilities and variations in pregnancy. Guideline S is the COVID one. So obviously, this is the newest guideline that was created, as if this section wasn't large enough. Guideline S talks about COVID infection in pregnancy and childbirth. How COVID-19, if it is the reason for the encounter or visit, you would report a code from 098.5, and you would also follow it with the U code for COVID, which is U07.1. If the admission is related or encounters unrelated to COVID-19, but the patient does end up testing positive during their visit, which if they did, they could have only gotten it because someone brought it to them. Um, if they're in a hospital and they didn't have COVID when they came in, it would still be the same. You would report the codes the same. One from the 098.5 category, the U07.1. And then when they say associated manifestations, that can mean anything else that the patient is being treated for during that period. So it could be related to, the COVID, if it's respiratory distress or cough or fever or whatever. You would report that. Well, you wouldn't report cough or fever. You would report respiratory distress because cough or fever is a symptom. Um, Asthma would be an example of something else that you would probably report. And that is chapter 15. So I'm actually going to stop there just because, let's see, 16, 18, 19. Because I want to spend a good amount of time on 18, 19, um, 18, 19, and 21. Just those three mainly. So, does anyone have any questions before we get off for tonight? So, what you could do between now and the time that I have the presentation loaded is, let me stop this. So, because